Hi students, a very good morning. This is Dr. Ramya here. So welcome to this YouTube series of AIIMS Target series. So this is the first series which we are going through. I hope my audio and video is clear. So on this platform of Unacademy, it's a live online coaching where you have the advantage of we have two courses being started this month. So I'll just have a look for you for those two courses. So one of the course which we are having is a integrated course. So one of the course which we are having is the foundation batch course. In the foundation batch course, all the subjects will be discussed detailed by your favorite educators online daily schedules which you have. So here are your educators which are going to discuss all the subjects, and it's going to start on your 27th January 2020 and the end date is 2nd November 2020. So there's a foundation batch course for NEET PG 21. Apart from that, you also have a integrated course where each topic will be taught to you in an integrated manner. So now as the NIMHANS exam is near, so there's a crash course for integrated batch course for mainly central nervous system. So some of your favorite educators are included in this integrated coaching to teach you CNS. So get up guys, and this is going to start on 29th March and 29th Jan, and it's going to end on 2nd March 2020, right? So coming back to our topic for today. A very good morning guys, very good evening guys. So starting with our AIIMS target series. So yes, I'm included in the all live and structured courses which we have just seen, and you can use the referral code given there for 10% discount. Okay, so let's start with the questions, and can I get a hi from the students? Is the audio and video clear? So here first which we are having is a EMQ, where in EMQ you have multiple options and questions. So each question you have to choose one option. So let's start with the EMQ. So the first one, a 27-year-old woman in her first pregnancy with no hi Akhilesh. So a 27-year-old woman in her first pregnancy with no identifiable risk factor for PPH delivers vaginally. What should be offered for management of third stage of labor? So they're basically asking you, so these are the options which you have. Yes, Akhilesh. So they are having a 27-year-old woman in her first pregnancy with no identifiable risk factor. So basically they're asking you among all these options, what can you give for active management of third stage of labor, AMTSL, right? So what is the best option here? What do you give for AMTSL? So it's nothing but the inject IM oxytocin 5 or 10 international units. That's the best for your active management of third stage of labor, right? So in active management of third stage of labor, we always give an oxytocic. So the oxytocic preferably is IM oxytocin. I don't tell that every time you have to give IM oxytocin only. Preferable is IM oxytocin 5 or 10 international units. And if IM oxytocin does not help, then we can, or if we don't have IM oxytocin, then we can go for methergin or misoprostol. But misoprostol, which is given prophylactic according to FIGO, is 600 micrograms, right? Let's see the second question now. A 32-year-old woman presents with mild vaginal bleeding 10 days post-delivery. She's well in herself with no pyrexia. She has no allergies. What is the most appropriate next step? So that's the puerperal pyrexia, right? Sorry, she's having only mild vaginal bleeding 10 days post-normal delivery. So she's well in herself with no pyrexia. What is the best next step we have? Misoprostol, oral ampicillin, oral clindamycin, surgical evacuation of uterus and retained products, or garboprost or pelvic ultrasound. So the bleeding up to 14 days is obvious, and as she is having mild vaginal bleeding 10 days post normal delivery, and she is well in herself with no pyrexia and she has no allergies, what is the most appropriate next step? So as there is, if you go with this question, they're asking you there is a bleeding after 10 days of normal delivery. So it might be because of a endometritis. It might be because of endometritis. So we have to treat it with antibiotics, that is the oral ampicillin and metronidazole. Oral ampicillin and metronidazole, right? So we'll just go through the answer. So here, the most common cause of secondary postpartum hemorrhage is infection or endometritis, which we can treat with oral antibiotics. Yet, so we can give the local RCOG recommends oral ampicillin and metronidazole. Why pelvic ultrasound is not the next step is because it is not going to change any of the situation, right? So that's why your pelvic ultrasound has no role as a next step. Better to go for directly the antibiotics, right? So let's go to the next question now. A 34-year-old woman. I cannot see any of you answering actually. A 34-year-old woman presents with heavy vaginal bleeding 5 days post normal delivery. 5 days post normal delivery. The woman is pyrexial and has been commenced on oral antibiotics by the general practitioner. However, she is not responding to the treatment. On admission, her blood pressure is 90 by 50. Her pulse rate is 120. On examination, she has a tender uterus. What is the most appropriate next step? So if you assess this question, so here there's a heavy vaginal bleeding. So the infection is severe and heavy vaginal bleeding points towards maybe there are some retained products because of which the mother is having heavy bleeding as well as she is pyrexial. And here in view of your pyrexia because of retained products, we have already started antibiotics, but that was of no help and she has a tender uterus. So which will be the best thing for us in this? So basically the patient in the third question has presented to us with in the previous question it was 10 days. The second question it was 10 days and the third question it is now 5 days post delivery. And she's also having associated pyrexia. She's also having associated pyrexia. right? So as there is associated pyrexia as well as so puerperal sepsis, is it only the surgical evacuation of retained products required or something else? Do you have a better option than D, Surya? So surgical evacuation of the uterus or retained products with consultant supervision and IV antibiotics. Along with evacuation, IV antibiotics will be the best, right? So we have to go with along with your surgical evacuation, plus you have to go with IV antibiotics, right? So the best answer here is I. So that's a EMQ on postpartum as well as PPH, right? Okay, let's see the next question now. Right, yes, that's the answer. There's a H also here. The pelvic ultrasound never changes any of our diagnosis, so that will never be the best management. Best management would be evacuating of the uterus and retained products with consultant supervision and IV antibiotics, right? Okay, let's go back to the next question now. A 32-year-old para 1 is 34 weeks pregnant. She has had one previous cesarean section. Ultrasound scan shows anterior placenta 1.5 centimeters from the internal os with irregular retroplacental sonolucent zones and abnormal placental lacunae. Color Doppler shows hypervascularity between bladder and serosa interface. What should be the management? Yes, Surya, Sauntar, Akhilesh. What is your diagnosis? What diagnosis did you make? 1.5 centimeters from the internal os. So whenever you have a placenta 4 centimeters from the internal os, it is nothing but your placenta previa. So here we are having it 1.5 centimeters from the internal os itself with an irregular retroplacental translucent zone, right? What is this irregular sonolucent zone and abnormal placental lacunae indicating? So that is nothing but placenta accreta, right? So this is a case of placenta previa with placenta accreta. So you have an irregular retroplacental. These are USG findings of your placenta accreta, that is irregular retroplacental sonolucent zone, abnormal placental lacunae, and Doppler showing hypervascularity between bladder and serosa interface. All these are the findings of placenta accreta, right? So when you have placenta previa and placenta accreta together, what will be the management? And she's a previous LSCS. She's a previous LSCS. Basically, that's the reason why she got this placenta accreta and placenta previa. And it's an anterior placenta. So although low-lying placenta, that is type 1, it is 1.5 centimeters from the internal os, suggests that it is a type 1 placenta previa. Although it's a type 1 placenta previa, it's associated with placenta accreta. So I rule out two options now. Yes, I rule out two options now, that is induction of labor. I will never go with induction of labor here, right? So now I'm left with delivery. Now, when do you want to deliver? It's 34 weeks or 38 weeks. Ideally, 34 weeks, lung maturity happens just at 34 weeks. So, basically, we always tell it as 36 weeks for placenta accreta to be delivered. But 38 weeks is also fair enough option than 34 weeks. So, the best answer here when you have a placenta previa associated with placenta accreta, elective cesarean section at 38 weeks. Right? Right. So, with regard to magnesium sulfate toxicity when used for treating eclampsia, what are the best answers which you have here? So it's a true and false according to your AIIMS pattern, where each true you will get a plus 1/5 mark and each false will get a minus 1/5 mark. Magnesium sulfate toxicity is associated with respiratory depression. Is it true or false? So that's a true, right? Your patellar reflex are the first to be lost whenever you have excess dose magnesium sulfate toxicity. So that's an absolutely true. So magnesium sulfate toxicity is associated with reduced patellar reflex. First patellar reflex is lost before your respiratory depression. So that's correct. So that's a true. Magnesium sulfate can cause both oliguria and anuria. So what do you think, guys? It can cause oliguria and anuria. What is correct about that? So magnesium sulfate causing oliguria and anuria is wrong, because magnesium sulfate does not cause oliguria or anuria. But when there is an oliguria or anuria, magnesium sulfate cannot get excreted. Magnesium sulfate is excreted unchanged in urine, and we want minimum 30 ml per hour urine output. Otherwise, we can't see the magnesium sulfate getting excreted, and there will be accumulation of magnesium sulfate. So magnesium sulfate does not cause oliguria or anuria, but oliguria or anuria will lead to magnesium sulfate toxicity. That's the reason why we monitor magnesium sulfate. So magnesium sulfate is excreted unchanged in urine. So this is a false. That's a false. Right? So the next one, magnesium sulfate can cause respiratory depression at serum levels of 2 to 4 moles per liter. Right. So what is the answer for that? So basically, if we go and see the magnesium sulfate monitoring, so magnesium sulfate monitoring, you have to always check for the patellar reflex, respiratory rate, and urine output. Patellar reflex, respiratory rate, and urine output. Patellar reflex, because that is the first to be lost whenever you have magnesium sulfate toxicity, right? And millimoles, your respiratory rate, because it can lead to respiratory depression. Urine output, as it gets secreted unchanged in the urine, right? So the therapeutic range of your magnesium is 4 to 7 milliequivalents per liter. 4 to 7 milliequivalents per liter, right? And at your 10 milliequivalents per liter, it gets changed to your patellar reflex is lost. Your 10 milliequivalents per liter, your patellar reflex is lost. And at 12 milliequivalents per liter, there is respiratory paralysis or your respiratory paralysis and coma occurs. And whenever your creatinine is more than 1.3, you have to halve the dose. We have to always halve the dose. That's very important, because if creatinine is not getting excreted, it means patient is having renal failure. So that's the reason what can happen is we can have the Right, so I see the answers here. So respiratory depression does not occur at 2 to 4 millimoles. That's also wrong because it's 10 milliequivalents per liter. Calcium carbonate can be used to reverse the respiratory depression caused by magnesium sulfate administration. So yes, it's not the calcium carbonate, it's the calcium gluconate. Right, very good Akhilesh, it's also a false. Magnesium sulfate crosses the placenta and causes fetal sedation. Yes, very good, Akhilesh. It will be 12 to 15 milliequivalents per liter. So that's also 10 to 12. So that's a wrong. Yes, it's a calcium gluconate. Correct. Magnesium sulfate crosses the placenta and causes fetal sedation is partially correct because sometimes it goes to the fetal when it has a mild fetal sedation effect. Apart from fetal sedation, it also has the neuroprotective. It has a benefit for the fetus as neuroprotective. So this is a true. Last one is a true, right? Right. Hi, Shrayan. Okay. So let's see the next question now. A woman in second stage of labor showing CTG as below. What should be the management? What should be the management? Sorry. So what is the CTG showing and what should be the management? So if we see the baseline, it is 150. Heart rate is, fetal heart rate is 150. That's very good. Beat to beat variability, it's going only in the one box, that to less than one box. So beat to beat is less than 5 beats per minute. Are there any accelerations? There are no accelerations, but we just see only decelerations, right? We only see a decelerations, right? So what type of decelerations are these? Very good, A1. It's the early deceleration. Excellent. So you can see the onset is matching with the your onset of contraction. Your nadir of the deceleration is matching with the peak of the contraction, and recovery is also matching. And you should always have them with every contraction. More than 50% of your contraction should show only, then we can call it as early. And here every contraction we are seeing an early deceleration. Why do we have early deceleration, A1? Yes, why do we have early deceleration? Yes, head compression. So in second stage, the head compression is pretty normal, right? So when you see a CTG like this with a head compression, with early deceleration, do you want to do anything? Or you want to wait and watch, or you want to go for forceps delivery, or you want to go to vacuum assisted delivery or emergency LSCS? So second stage mein head compression is pretty normal. We don't require to go for anything. We can just wait and watch for the delivery to happen. And already she is full. So we have to just see for her pushing, right? So we don't require to do any instrumental delivery here. If it would have gone to late deceleration, then we would have thought about the forceps or vacuum assisted delivery. But as of now, it's not required. Right. Yes, it's just the wait and watch. Okay. Right. Let's go to the next question. Identify the red line. So what does the red line indicate? Obstetric conjugate, true conjugate, diagonal conjugate, bispinous diameter. Yes, Akhilesh, Rayan, true conjugate, right. Please remember this way, I asked for the red line. So this is for the inlet, right? So always remember this way, remember it as dot. You can remember it as dot, D-O-T dot, D-O-T. From below upwards, it is D-O-T dot. So D is the diagonal conjugate. O is the obstetric conjugate, T is the true conjugate. D is the diagonal conjugate, O is the obstetric conjugate, T is the true conjugate. So what you are seeing, the red line is the obstetric conjugate. It's not the true conjugate, right? How do you calculate which conjugate we can calculate? So it's the diagonal conjugate which we can calculate by doing the PV, that is from the lower border of pubic symphysis to the sacral promontory, whereas obstetric conjugate will be calculated from your diagonal conjugate, right? So this is 12 centimeters, diagonal is 12 centimeters, obstetric is 10.5 centimeters, and true conjugate is 11 centimeters, right? And the red line is the obstetric conjugate, posterior surface of pubic symphysis to the sacral promontory, right? Speaking about the hormone replacement therapy, again a true and false, you have to decide which statements are true and which statements are false. Yes, very good, A1. Yes, diagonal conjugate is always measured as, obstetric conjugate is measured as diagonal conjugate minus 1.5. Right, correct. So HRT decreases the risk of breast cancer, increases the risk of osteoporotic fractures, increases the risk of thrombosis, increases the risk of stroke, reduces the risk of colorectal cancer. Right, I have true, false, true, true, true. Okay. Decreases the risk of breast cancer. Your hormone replacement therapy, when you use it for more than 5 years, you always have increased risk of breast cancer according to Women Health Initiative trial. So it does not decrease, it increases the risk. So this is a false. It increases the risk of osteoporotic fractures is false because it's used in the treatment of osteoporosis. This is also false, right? Increases the risk of thrombosis. Yes, you have increased risk of thrombosis. Increases the risk of stroke. Yes. Reduces the colorectal cancer. Yes. It is protective against colorectal cancer is true, but it increases the risk of breast cancer. So you can see here, when you use it for more than 5 years, breast cancer risk is increased. It increases the risk of coronary heart disease. It increases the risk of venous thromboembolism. It increases the risk of cholecystitis and ovarian cancer also when you use it for more than 10 years. So it increases the risk of coronary heart disease, breast cancer, venous thromboembolism, cholecystitis and ovarian cancer when you use it for more than 10 years, right? So hormone replacement therapy, false, false, true, true, true. So one last, we can see the clomiphene citrate. Clomiphene citrate is is again you're having a true and false, so you can answer in the true and false fashion. Yes, I'm waiting for your answers. Is an anti-estrogen, decreases the serum FSH level, raises the incidence of twin pregnancy to 30%, can cause ovarian hyperstimulation, may increase the risk of ovarian cancer when used for 3 months. So clomiphene citrate is an anti-estrogen is correct. It's a selective estrogen receptor modulator, which sometimes act as anti-estrogen, some receptors pro-estrogen. So it's anti-estrogen is true. It decreases the serum FSH levels is an absolute false. Your clomiphene citrate goes and blocks the FSH receptors on the pituitary. As it blocks the FSH receptors on pituitary, it increases the uh, estrogen is not perceived. As estrogen is not perceived, so no negative feedback, it increases the levels of FSH, right? It blocks the estrogen receptor. So false. Raises the incidence of twin pregnancy to 30%. Gonadotropins will raise the twin pregnancy to 15 to 30%, but your clomiphene citrate maximum 5 to 8%. So you can go with 8 to 10%, but not 30%. It's a false. Can cause ovarian hyperstimulation? Yes, it can cause ovarian hyperstimulation. So this is a true. May increase the risk of ovarian cancer when used for 3 months. So clomiphene citrate, when you use it for more than 3 months, it definitely has the risk of, we can maximum use it for 6 months. It's not only for 3 months that it has the risk of ovarian cancer. It has a risk of ovarian cancer, but not when used for 3 months. We can use it for more than 6 months. So this is also false. So we have a true, false, false, true, false, right? So that is regarding the clomiphene citrate. So basically it's a selective estrogen receptor modulator, and we use it for ovulation induction. We start them on 50 milligrams, maximum we can give 150 milligrams. We start it on day 1 or day 2 of cycle, and we give it for 5 days. OD dose, right? Success, your pregnancy rate with clomiphene citrate is 40% cumulative, whereas ovulation rate is 80%. The cumulative pregnancy rate is 40%, ovulation is 80%. We have so much half variation because it is anti-estrogen to your endometrium. So endometrium will be thin because of the anti-proliferative effect, right? And one more thing which we should be knowing about the clomiphene citrate is it has a very dangerous one side effect which is particular to clomiphene citrate, that's a visual disturbance. And whenever you have visual disturbance because of clomiphene citrate, you never use this drug back again. Okay. So that was regarding today's session of NEET, Target AIIMS series. So we'll be coming back again with the next series. So tomorrow I have the class again at tomorrow again we can join back in the session at around 11:30 a.m. Sorry, it's not 11:30 a.m. 12:30 in the afternoon, right? So thank you guys. Keep studying, start studying. It's a high time where you have to start studying. So make a good plan and make a initiate it, but definitely start studying so that you don't have to club everything at the last. So yes, from now itself you have to start studying and make a plan. That's very important. How many hours for each subject, and go according to the plan. So all the best guys. Thank you. Yes, Akhilesh, if it is within 4 days, it's definitely going to be a lochia rubra. So we don't require to do anything if she comes back to us, unless until they mention it's that is a heavy bleeding. If it's not heavy bleeding, then we can consider as lochia and not do anything. That's 100% correct as you are asking. If it's 4 days, definitely no issue. So usually we have excess bleeding within 1 week, lochia rubra within 1 week, right? Any other query, guys? Thank you.